Okay, our topic for today is seronegative arthritis. Okay, before going to that, let us briefly describe the classification of arthritis. That is, arthritis is broadly divided into, we all know, inflammatory and non-inflammatory. And among the inflammatory, we can see four categories, that is seropositive, seronegative, infectious arthritis, and crystal induced, that is gout and all other things. Okay, and among the seronegative, we can see four types, that is ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease arthritis, that is enteropathic arthritis associated with ulcerative colitis and Crohn's disease. Okay, so our topic for today is the seronegative arthritis, that is ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease. So, what is seronegative arthritis? That is arthritis that is negative to the rheumatoid factor or other autoantibody serologic abnormalities. So, these arthritis are negative to rheumatoid factor especially and also other autoantibodies. So, no autoantibody is detected in these arthritis patients. Okay. Now, all the categories, the spondyloarthropathies. Spondyloarthropathies, what is the definition? It is a group of inflammatory arthropathies that share distinctive clinical and radiographic and genetic features. These include ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and enteropathic arthritis. Okay, let us discuss one by one. Before going to that, there are certain common features for these four types of arthritis. Let us see the common features of these arthritis. That is these spondyloarthropathies. Okay, common features. One, we already know, that is by definition, it is a negative for rheumatoid factor. So, rheumatoid factor is absent, and also there are no rheumatoid nodules. And the most important finding is it is frequently associated with HLA-B27. Remember that. And a tendency to occur in same family, that is familial aggregation. There will be family history of arthritis. And also inflammatory axial arthritis, generally sacroiliitis and spondylitis. Most important thing. So, generally it is sacroiliitis and spondylitis. Alveolar arthritis generally with asymmetrical presentation, and also enthesitis, that is inflammation of entheses. What are entheses? The sites where tendons or ligaments insert into the bone. Most commonly it is plantar fasciitis, also achillotendinitis, and also costochondritis. But most commonly it is plantar fasciitis and Achilles tendinitis. We can see in most of the patients. And also extra-articular features. This is also one of the main important association of these spondyloarthropathies. They are always, most frequently, they are associated with extra-articular features like involvement of eyes, anterior uveitis, skin, and genitourinary tract. So, this is the percentage, degree of associations. So, most strongly associated is ankylosing spondylitis. We can see here. So, ankylosing spondylitis is strongly associated, 90% of association with HLA-B27. Least is psoriatic arthritis. Least percentage of association with HLA-B27 is, we can see it with psoriatic arthritis. And Reiter syndrome or reactive arthritis, that is 80%. And this is enteropathic arthritis, that is IBD related, it is of 75% association. Now let us discuss the most important topic, that is ankylosing spondylitis. It is a chronic inflammatory disorder of unknown cause that primarily affects axial skeleton, peripheral joints, and extra-articular structures. We already discussed, these are the things which were present in the common features. And we have already seen 90% of patients are HLA-B27 positive. And incidence is most common in men than women. When it comes to ratio, it is 3:1. This is the most important point. Age of onset is typically between 20 and 40 years. Most commonly, it is the young male will be presenting with the symptoms of ankylosing spondylitis. Okay, so remember that it is most commonly seen between 20 to 40 years, and that is young males. And more commonly, it involves the axial skeleton, although peripheral joints may also be affected. Now, let us see what's the pathology of ankylosing spondylitis. Sacroiliitis is the earliest manifestation of ankylosing spondylitis. Remember this, sacroiliitis is the earliest manifestation. Most commonly, these young males will present with a sciatic type of pain. Okay. And synovitis, pons, myxoid marrow, subchondral granulation tissue, and marrow edema are found in these patients. And in spine, there is inflammatory granulation tissue at the junction of annulus fibrosis and vertebral bone. And also these outer annular fibers are eroded and replaced by bone. That is, it forms a syndesmophyte. So let us see the histopathology, how it will be. Okay, inflammatory cells in ligamentous and periosteal area. First, there is infiltration of inflammatory cells in ligamentous and periosteal area. Then there is development of subchondral marrow edema, and there is development of panas and newborn formation because of there is development of new blood vessels and new blood supply and formation of a panas and newborn formation. Finally, due to the increased blood supply, and there we can see the bony erosions and also fibrocartilaginous regeneration and ossification. This is the histopathology. Now let us come to the pathogenesis. Thought to be it is immune mediated, but there is no direct evidence. There is uncertainty regarding the primary site of disease initiation because we don't know what is the primary site of disease initiation yet. And the squaring of vertebral bodies is one of the distinctive feature of ankylosing spondylitis. You have to remember this. This is the most important point. Squaring of vertebral bodies, and also we can see early radiographic signs of enthesitis. Okay, the squaring of vertebral bodies. How it is found? Because of erosions of superior and inferior margins of vertebral bodies. Actually, normally there is concave contour of the anterior surface that is lost, resulting in loss of normal concave contour of the anterior surface, and also loss of superior and inferior margins of vertebral bodies. Finally, it leads to squaring of vertebral bodies. And also, another important feature is bamboo spine. It is characteristic of ankylosing spondylitis. This is the most important point you have to remember. Bamboo spine. Okay. Thin and slender syndesmophytes are generally evident, representing ossification of the outer layer of annulus fibrosis. So we can see thin and slender syndesmophytes. These are generally marginal in ankylosing spondylitis. Remember this, these are generally marginal. Okay. On AP lumbar spine radiographs, the syndesmophytes thicken, become continuous, giving knobbly appearance. Okay. Now we can see the pictures here. This is a healthy spine, body of vertebra. You can see the concave contour. Okay. And also see here in ankylosing spondylitis, this is the inflammation of joints, and the final there is fusion of bones. See, this gives a picture of bamboo spine for us. Okay. Understand? See the concavity, which is very clear here. It is lost. The concavity is lost here. You can see clearly. Okay. And finally, because of the fusion of bones, bamboo spine. This is the appearance of a bamboo spine. Okay. Characteristic of ankylosing spondylitis it is. Okay. Again the same thing, formation of syndesmophytes, fusion of days. Okay. Let's go to the clinical manifestations. How the patient will present to you. As I already told you, young male, that is late adolescence or early adulthood. Median age is being 23. So initial presentation of ankylosing spondylitis generally occurs in the sacroiliac joint. I already told you it may be mostly it will be like a sciatica like pain. So most commonly it occurs in the sacroiliac joint. Involvement of sacroiliac joints is required to establish the diagnosis. It is the most important clinical feature. Okay. So symptoms are usually first noticed in late adolescence or early adulthood. So the initial symptom is usually the late adolescent or early adult. This patient usually presents with dull pain felt deep in lower lumbar or gluteal region, and it will be more in the morning hours, and there will be early morning stiffness. That is the most important point to be noted. Early morning stiffness up to few hours of duration, and it improves with the activity. Okay, and sometimes there will be nocturnal exacerbation of pain, and this because of this patient mostly rise and move around. Okay, he can't sleep properly because of this severe pain which is aggravated in the night times. His sleep will be disturbed. He is forced to get up and he will be moving so that his pain is relieved. This is the classic presentation. Okay, you just remember that there is a most initial presentation is the involvement of sacroiliac joint, and the patient is mostly of early adulthood or late adolescence, and the median age is being 23. Okay, just remember that. And sacroiliac joint involvement is followed by involvement of discovertebral, apophyseal, costovertebral and costotransverse joints. Okay. See, I have already described how the initial symptom is. It is usually dull aching pain. So it is insidious in onset, felt deep in lower lumbar or gluteal region. It is also associated with stiffness of up to a few hours of duration that improves with activity and returns following inactivity. Okay, remember this. This is the most important point. Low back, which is associated low back pain associated with morning stiffness. Okay, and also there is arthritis in hips and shoulders occurring in 25 to 30% of patients. And arthritis of peripheral joints other than hips and shoulders, usually asymmetric, occurs in another 30% of patients. Okay, now we can just see the picture. This is stooped over position of advanced ankylosing spondylitis. Because of the fusion of vertebral bodies, there is decrease in length of spine, and also patient will be stooping forward. Okay, this is stooped over position. Neck pain and stiffness from the involvement of cervical spine are late manifestations, because early involvement is sacroiliac joint. The cervical involvement is a late manifestation, which can be seen as neck pain and stiffness. And also there is decrease in chest expansion, which is measured as the difference between, as we already know, maximal inspiratory and the maximal forced expiratory expiration in the fourth intercostal space. Normal chest expansion is, as we all know, it is greater than or equal to 5 centimeters. If the chest expansion is less than that, then it is one of the clue to the diagnosis of our ankylosing spondylitis. Normally the chest expansion is reduced in ankylosing spondylitis. Okay, and also there is restriction of lumbar movement. See, movement of spine is always it is decreased in ankylosing spondylitis. Why? It is because of fusion. See, two vertebral bodies are getting fused, so they cannot move. So there is restriction of movement of vertebra. So there is for lumbar movement restriction, we can see Schober's test. We can do the Schober's test. See, you have to do, mark the patient's back at the level of posterior iliac spine. Now place one finger 5 cm below this mark and a second finger 10 cm above this mark. So mark 5 cm below posterior iliac spine and 10 cm above posterior iliac spine. Okay. Now patient is instructed to touch his toes. So when the patient do this, the distance between fingers should be increased by greater than 5 centimeter. That is again here also the same, just like chest expansion, which is what is the normal. Greater than 5 centimeters of expansion is normal. Even in the Schober's test, the distance between the 2 points should be increased by more than 5 centimeters. If the distance between the 2 centimeters is less than 5 centimeters, then the lumbar flexion is limited. Okay. First you just mark 2 points. First you mark a point at the posterior iliac spine. Okay, this point 0. Now you draw a point 10 centimeters above and 5 centimeters below. Okay, so now you ask the patient to bend, and if the distance between the 2 points, that is the point at 10 centimeters and the point at 5 centimeters, 10 centimeters above, 5 centimeters below the posterior iliac spine, the difference between these 2 points should be increased by more than 5 centimeters. If that doesn't increase by more than 5 centimeters, that is less than 5 centimeters, then lumbar flexion is limited. Understand? See, you can see here. First we are marking at 0. This is posterior iliac spine. First we are making a point here, and then we are marking a point 10 centimeters above posterior in iliac spine, and also 5 centimeters below the posterior iliac spine. Now we are asking the patient to bend forward. Okay, ask the patient to touch his toes. He is instructed to touch his toes, and you can see the movement. How much the distance is increased between the point above, that is about 10 centimeters above the posterior iliac spine and 5 centimeters below posterior iliac spine. It should be increased by increase. If it doesn't increase more than 5 centimeters, or if the distance between the two points is increased by less than 5 centimeters, then lumbar flexion is limited. So chest expansion is limited. There it is the normal is greater than or equal to 5 centimeters. If it is less than 5 centimeters, chest expansion is limited. In the same time, in Schober's test also, the distance between the 2 points which we have marked should be increased by more than 5 centimeters. Even here, If it is less than 5 centimeters, lumbar movement is limited. Okay, so remember both are 5 centimeters. That is, chest expansion should be more than 5 centimeters, and also the lumbar movement, that is also should be more than 5 centimeters. Okay. Now, peripheral musculoskeletal involvement. It occurs in 30 to 50% of all patients, and the following are common. That is Achilles tendinitis, plantar fasciitis, at the tibial tuberosity, superior and inferior poles of patella, and iliac crest. These are the peripheral musculoskeletal involvement. It occurs in 30 to 50% of all patients. Okay. Now we have already discussed in the what we say common features of spondyloarthropathies. That is, one of it is extra-articular manifestations. In that, most common is extra-articular manifestation of ankylosing spondylitis is uveitis. Okay, see, uveitis is the most common extra-articular manifestation of ankylosing spondylitis. It occurs in 20 to 30% of patients, and usually it is acute and unilateral non-granulomatous. Okay, remember this. Another extra-articular manifestation is cardiovascular disease. We already know it is aortitis leading to aortic wall insufficiency, that is AR. Okay, acute aortic regurgitation, and also mitral wall insufficiency, mitral regurgitation, and heart blocks. Okay. Other extra-articular manifestations: pulmonary disease, we can just go through it, restrictive lung disease, and also bilateral apical pulmonary fibrosis. When it comes to renal amyloidosis, it is a very rare complication. And also in GI disease, asymptomatic inflammation of proximal colon and terminal ileum has been observed. Okay. Now let us discuss laboratory findings. See, there is no laboratory test that is diagnostic of AS. Okay. Remember that point. There is no specific test for diagnosing AS. Okay. HLA-B27, as we already discussed, it is 90% association of 90% it is associated with HLA-B27, ankylosing spondylitis. Least association is for psoriatic arthritis. It is 50%. Okay. And also we already know ESR and CRP are elevated since it is inflammatory, and mild anemia may be present. And patients with severe disease shows an elevated alkaline phosphatase levels. Okay. And elevated serum IgA levels are common. See, RA factor, anti-CCP, ANAs are negative. See, they are absent because it is a seronegative arthritis. So, the RA factor and other autoantibodies will be absent. Now, let us discuss radiographic findings. Earliest signs can be detected by 3 to 6 months after the onset. So, sacroiliac joints. Early patchy osteoporosis develop around the distal third of both the bones. Okay. Around the joint there will be development of osteoporosis and we can see because of development of osteoporosis, the joint margins become ill-defined, and it will look like the joint space is widened. Okay, joint margins become ill-defined and the joint intervals become widened because of osteoporosis. Okay, and also there is subchondral erosions which start, and when multiple produce a rosary effect, subchondral bone erosions will start. Okay. See, this is lumbar spine. Earliest changes we have already discussed: squaring of anterior portion of vertebral bodies. That is loss of concavity, which is natural. We have already seen the picture. There is loss of concavity and there is squaring of anterior portion of vertebral bodies. This is the earliest change. Okay, you can see here. Okay, squaring of anterior portion of vertebral bodies. This is found initially at the upper lumbar and lower thoracic regions. And also there will be loss of lumbar lordosis. Okay. Next, paravertebral ossification develops beneath the anterior longitudinal ligaments. Beneath the ligaments there is development of ossification, and this ossification will give the appearance of bamboo spine. Okay, this is the most important characteristic finding. Okay, bamboo spine. That is because of the paravertebral ossification which is developing beneath the anterior longitudinal ligaments within the annulus at each level. Okay, bamboo spine. When it comes to cervical spine, extreme bony bridging extends along the anterior aspect of vertebral bodies, and there will be loss of lordosis, and apophyseal joints become ankylosed. That is fusion of apophyseal joints and also loss of normal curvature of the cervical spine. That is, there is loss of lordosis, and also there is bridging along the anterior aspect of vertebral bodies. This is seen in cervical spine. When it comes to hips, there is severe osteoporosis. See, sacroiliac joint is most commonly involved and also most severely involved joint. There is severe osteoporosis occurs in both sides of joints, and also erosions develop and the joint space becomes reduced. Okay. Now this is the classification criteria for axial spondyloarthropathies. Okay. When there is sacroiliitis on imaging, there should be placed at least one more than one spondyloarthropathic feature. If it is HLA-B27 positive, there should be more than two other spondyloarthropathic features. Okay. How do you define sacroiliitis on imaging? We can see here active inflammation on MRI, highly suggestive of sacroiliitis associated with spondyloarthritis. Okay. There should be active inflammation on MRI or definitive radiographic sacroiliitis according to modified New York criteria. So just remember that if there is sacroiliitis on imaging, there should be at least more than one spondyloarthritic feature. If it is patient is HLA-B27 positive, then there should be more than two spondyloarthritis features. Now we can see what are the features of spondyloarthritis for in this classification, ASAS classification for axial spondyloarthropathies. Okay. What are those features? Number one is inflammatory back pain, as we already know. See, first, very easy to remember. One is symptom, that is back pain. Next is involvement of joint, arthritis, and also insertion of tendon or ligament site, enthesitis, extra-articular manifestation, uveitis, okay, and dactylitis. And now let us come to what are the diseases coming under spondyloarthropathies? 4. That is, one is ankylosing spondylitis. Okay. Number 2 is inflammation, that is enteropathic arthritis. So you can see Crohn's disease and ulcerative colitis. Next, reactive arthritis. Another one is psoriatic arthritis. So that is also included here. Psoriasis. So simple. Psoriasis, Crohn's disease, ulcerative colitis. See, arthritis. There should be good response to NSAIDs. We are going to treat with NSAIDs, right? So there should be a good response to NSAIDs. And as we already discussed, these are the common features. As we have already seen, those are the same. Those points are repeating here again. See, family history of spondyloarthropathies. And we have already discussed HLA-B27 positive, these patients. And also there should be elevated CRP. Okay. These are all common features of spondyloarthropathies, if you remember, as we have already seen in the starting. Okay. So simple. Just remember that there is inflammatory back pain and also arthritis, enthesitis, uveitis, dactylitis. Now let us come to the classification. Psoriasis, Crohn's disease, ulcerative colitis. Now let us come to the treatment. There should be good response, and also family history should be there, and also HLA-B27 positive, elevated CRP. Okay, these are nothing but this all common features of spondyloarthropathies. So inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, ulcerative colitis. Treatment, good response to NSAIDs. There should be family history. HLA-B27 should be positive, elevated CRP. Okay. This is the classification criteria for axial spondyloarthropathies. See, this should be applied only in patients with back pain which is present for greater than or equal to 3 months and age of onset is less than 45 years. Remember this point. Okay. This is the most important point. Okay. This one. Okay. Next. See, as I already told you, to qualify the criteria for inflammatory back pain of axial spondyloarthropathies, it should be chronic, that is more than 3 months, and should have 4 or more of these following features. Age of onset below 45 years. Sorry, this is 45 years. Okay, and it should be insidious in onset, and there should be improvement with exercise. Improvement will be no improvement with rest. Improvement upon getting up. As I already described you, we have already discussed clinical features. In clinical features of ankylosing spondylitis, that there will be improvement with the exercise, and also there is nocturnal exacerbation of pain which will be improved upon getting up, as we have already discussed. Okay. Now when it comes to treatment, general measures. See, patients are encouraged to remain active because if the patient takes rest, there is increase in pain. So patient should remain active. So they should be taught to maintain satisfactory posture, to perform spinal extension exercises every day. Swimming, dancing, gymnastics are ideal forms of recreation. Rest and immobilization are contraindicated. See, remember this. As I already told you, Rest increases the pain because they tend to increase the pain and increase the general feeling of stiffness. So patient is not allowed to, that means not encouraged to take rest and immobilize. Okay, generally we say to the patients, okay, I'm having pain, then take rest. So it is contraindicated in these patients. We have to advise the patient to remain more active than passive. Okay, and we have already discussed in the classification also, and also in the common features of spondyloarthropathies. That is, there should be good response to NSAIDs. So the drugs, when it comes to NSAIDs, if the NSAIDs improve spinal pain, peripheral joint pain, and function over a short period of time within 6 weeks, but they don't prevent or retard the progress to ankylosis. So these is just give you the symptomatic relief. This doesn't reverse the disease process, okay, or this doesn't prevent or stop or retard, okay, the process. So this will only provide you symptomatic relief. In order to stop or progression of the disease, we can start TNF inhibitors. Okay, what are they? Etanercept, infliximab, adalimumab, golimumab, and certolizumab pegol. These are all approved. Okay, TNF inhibitors. When it comes to infliximab, it can be given IV. Infliximab is given IV. Just remember II. Okay. Adult dosage is 5 mg per kg at 0, 2, and 6 weeks, and then every 6 weeks. When it comes to etanercept, it is given subcutaneously 50 mg once weekly or 25 mg subcutaneously twice weekly. Okay. When it comes to adalimumab, 40 mg subcutaneous every 2 weeks. These therapies are generally reserved for individuals who have failed to be controlled with NSAIDs. When NSAIDs fail, we can go for TNF inhibitors. Okay. And finally, last option is joint replacement. Okay, patient with significant involvement, as I already told you, sacroiliac joints are most commonly involved. Most early involvement is and also severely involved joint. Okay, so these patients may be benefited with total hip arthroplasty. Okay, friends. Okay, in next video, let us discuss about other types of seronegative spondyloarthritis, that is reactive arthritis, and entropathic arthritis, and